crowning, okay? We can also observe that area and see if there is in fact crowning present. We want to ask the patient, and this is on your sheet, it's number 2, we want to get our focused history. So we want to ask her, and there's several questions we're going to ask. We use the mnemonic pledge and bow, okay? So bow stands for bag of waters. Want to ask the patient, did your bag of waters break? If so, when? Where were you when the bag of waters broke? We also want to know some details about the bag of waters. So, for example, was there any particular odor or any particular color? Because that's going to it's going to indicate that we may have a potential problem. If there is an odor of the water, or if it's brown or yellow, that would tell us that we need to get ready for suction, because the baby, what happens is the baby, if they're under a lot of stress in the womb, they may have a bowel movement, okay? If that happens, we're really concerned about pneumonia, aspiration pneumonia, and that baby inhaling the feces into their lungs, it's going to make them sick. So if, in fact, the bag of waters had any particular color or odor to it, we need to be ready to suction when that baby comes out, and do some real good, thorough suctioning to hopefully prevent any pneumonia from actually setting in. Okay? So pledge and bow are the mnemonics that we're going to remember. Bows, what?
Bag of water.
Good. And then P, what's the P? Rod? Prenatal care? Okay. So are you getting any prenatal care? Have you been seeing a doctor? Has the doctor warned you of any potential problems? Are you taking prenatal vitamins? Are you on any medications? L is the last menstrual cycle, correct?
Yes, sir.
Okay. So when was your last menstrual cycle? Hopefully it was about 9 months ago. If it was only 7 months ago, then could have a problem, right? We got a premature baby coming on us. So we need to know the last menstrual cycle. E is expected complications. Are you expecting any problems with this delivery? Can you guys name a few that might pop in your mind?
Preeclampsia.
Eclampsia, what? Umbilical cord around the neck, okay. Any others? Yeah, breech. Breech delivery would be a big concern. That's when the baby's feet are down, and we're expecting the feet to come out first rather than the head to come out first. Or the butt would be a breech delivery as well. So
What if the mother's had a previous C-section?
no problems.
No?
I mean, that's something to make note of and to remember, but they can still have vaginal delivery after the previous C-section. Okay? But that could indicate that, we may have a need for another C-section at this point. So you're just going to note it down and remember it when you bring the patient to the hospital. What does D stand for in pledge? Drugs and or allergies, right? What else did you say?
Allergies, medications.
Drugs, allergies, medications, okay? And then G?
Gravida para.
Gravida para. So the way that I remembered it when I was in school is gravida. I can do this real well. You ready? Gravida is the number of times she's actually grown or she's been pregnant, okay? Whereas para, gravida starts with a G, so grow. Para is the number of times she's actually pushed out a live birth, okay? Or, yeah, a live birth.
What about stillborn?
Stillborn then is just a gravida, but it's not a live birth. Okay. And then E is
Expected due date.
expected due date, right? So we need to know that to help us determine, again, if we're late, if we're early, so on and so forth. The other thing regarding to the para and gravida, if the lady, for example, has been pregnant 5 times, she's had 5 kids, is that a warning to you? I mean, do you need to be what is important about that? What information?
The baby might fall out.
The baby, I don't know about fallout, but the baby's, yeah, you're going to have a faster delivery. So you want to get prepared quick. I have yet to see a baby just actually fall out. I really don't think that's going to happen. Terry, have you ever heard of a baby just falling out?
Well,
No.
I think come out in one push.
One push, okay, yeah. So
Basically falling out.
that can happen, but they don't just fall out, all right? All right, so then after that, that's when we actually determine that delivery is imminent. We want to look for crowning for the mom's need to bear down. We also want to get a time of contractions. So generally that cutoff time that we're looking for is contractions are closer than 3 minutes apart. And that's from the start of one contraction to the start of the next contraction. So if the contractions are less than 3 minutes apart and or they last like more than 2 minutes, that's a sign that delivery is coming near, okay? Then we're going to prepare our OB kit. So we're going to pull this stuff out. We want to put stuff under her rear end, okay? Because who's actually seen a childbirth and or delivered a child in here? Okay, good. What happens during childbirth? Everything comes out, right? Anything and everything. So this is one of those cases where we need to make sure and have all of our PPE on, a gown, goggles, because there could be stuff flying everywhere. So we want to be prepared for it, okay? So we're going to put something underneath her. We also want to give her some protection or some coverage, all right? So we can cover over the top. And we're not really creating a sterile field, but we're going to keep it as aseptic or as clean as we possibly can, all right? So we're going to drape the patient, put something underneath her to catch all the goo. Then the baby's head's going to come out. Now before that, we can actually cleanse the perineum. So we're going to take our towelettes and we're going to cleanse the perineum. That's the area between the vagina and the anus. We want to clean that area. Why?
Infection.
Yeah, because one, there's a lot of gook coming out, and two, we want to make sure it's good and clean because it could tear, and if it tears, then the woman could get infection. So we're going to try and clean that area as best as we can. All right? So as the baby's head comes out, we're just going to apply gentle pressure. And this is primarily for, as I mentioned, those women that have had babies that just fall out. Okay? We're going to just apply gentle pressure to prevent sudden expulsion. What's really funny is I hear students say sudden explosion. The baby's not going to explode, okay? It's going to potentially expulsion out of the vagina. So we're just going to apply gentle pressure to prevent it from sliding out, okay? And then I'm trying to follow your steps because they've kind of changed here. Okay, so we're going to tell the patient, push with each contraction. Eventually the baby's shoulders are going to come out. Could be the bottom one coming out. If the bottom one's the first one will come out, we're going to apply gentle upward pressure to help it come out. And then the same thing on the top shoulder. Apply gentle downward pressure to help the top shoulder come out. Okay? Now, when the baby's head comes out, we're going to suction. These bulb syringes you squeeze in, and then when you let go, it sucks. So we're going to suck. And then squirt it out. Squirt it out. Always do the mouth first, and then the nose. That's what you guys are taught, right? Because if you stick something in the nose, what happens? You go, and if there's any meconium or what have you in their mouth, then they'll inhale that into their lungs. So do the mouth first and then the nose. Good suctioning. All right? So then when the baby's neck or the head and the neck come out, we want to make sure the cord is not wrapped around the neck. What if the cord's wrapped around the neck? Yep. Stick a couple fingers in there and try and pull it and unloop it from around the neck. If it's too tight and you can't do that, then what?
You clamp it.
Clamp it and cut it. You got to get it off there, otherwise it's going to choke the baby and the baby will die. Okay? All right, so the head and the neck are out. We suction the nose and the mouth. Okay, so we're going to instruct the patient to go ahead and push and keep pushing the baby out until the baby's all the way out. Once the baby's all the way out, who hasn't held a baby in here? Everybody's held a baby? A newborn baby?
Oh, no.
With the floppy heads? Yeah? Okay. Just make sure and provide support for the baby's head, because if you don't, the head will just go flop. Okay? So we're going to hold the baby. We're going to suction again. Mouth. And the nose. Okay? And then we're going to dry, warm, and stimulate the baby. So we want to dry them off. This, in and of itself, is usually enough, at least on a healthy child, to stimulate them enough to get them to start breathing and crying. We're going to dry all the stuff off of them, okay? And we can wrap them up as best we can, although I know they have the umbilical cord still on. But usually that's enough to stimulate them to get them to start crying. If it's not, we can flick the bottom of their feet What did you guys watch the video, childbirthing video?
Yeah.
Yes, no. Some people are saying no.
Much rather give birth again than
Okay, what
watch
did they
that
tell you
video.
for stimulation?
Did the eyebrow too?
Flick the feet, the eyebrows, just flick the eyelashes.
I think so.
Yeah, I mean just gentle pats on their back, and you'll probably get them to start breathing. All right. All right. So now we're going to clamp the cord, and this doesn't actually give the location, but basically we're going to clamp the cord 4 to 6 inches from the baby. So maybe in this area, okay? And we have clamps. These are actually scissor clamps, but you have these. You just put them on here and you push them down, okay? 4 to 6 inches from the baby, another 2 inches from that, okay? And then we're going to cut in the middle, all right? They say you want to wait until the cord stops pulsating, so the blood circulation to the baby from the placenta has stopped, and then we'll go ahead and cut it, all right? At this point then, we're going to do our 1 minute APGAR. Have you guys learned APGAR yet? No, okay. The book does a good job of explaining APGAR. We're going to give a point range. Are you writing up there? No? Yes? Okay. So the point range is 0 being the worst to 2 being the best, all right? So for appearance, the first A in APGAR stands for appearance. If the baby's blue all over, that's bad, right? So we're going to give them a 0. If the baby has pink extremity, or I'm sorry, pink core, but blue extremities, they get a 1. That's okay. If they have pink all over, then they get a 2, okay? So we're going to score them at the 1 minute for appearance. P is for pulse. I'm pretty sure the book says pulse over 100, they get a 2. A pulse, but under 100 is a 1. And remember, where are we going to check pulses on these guys? The brachial artery, right. Okay, and if they have no pulse, it's a 0. Okay? Grimace is a cry, so if they have, I think the book makes it real basic. If they have a good strong cry, it's a 2. Kind of a weak or a faint cry, it's a 1. No crying, a 0. And then activity, same thing, 2, 1, 0. If they're active, moving all their extremities, that's good. One way you can check is you can kind of pull their legs away from them, extend their legs away from them. If they pull them back, that's a good sign that they're moving well. Okay, but the good activity is going to be a 2. Slight activity is going to be a 1. Absolutely no activity is going to be a 0. And then respirations. If respirations are over 30, we're good. That's a 2. Under 30 is going to be a 1, and 0 is going to be a 0. Okay? So we're going to calculate the APGAR at 1 minute after birth, and then we're going to do it at 5 minutes after birth. So you have to calculate it twice. And hopefully we'll see improvement. Okay? Initial APGAR may be around 7 or so, 6, but the second APGAR we're hoping is going to be a 10 or close to a 10. That's a good baby. Okay, so after that then, we're going to hand the baby to the mom. Here you go, Mom. All right. We're going to wait for the placenta to come out. The cord's attached there, but the rest of the cord would come out with the placenta. All right. When the placenta comes out, just kind of take a look at it. They don't look like this at all. They look like a big red blob. Just kind of look at it and see if anything looks abnormal to you, although I know you probably aren't going to know what it's supposed to look like normally. You want to put it in a bag and bring it with you to the hospital for the doctor to inspect. Okay? And then after that, we're going to look at the mother, assess the mother for any excessive vaginal bleeding. If she has some, remember we can elevate the hips, use gravity to work for us. We can place padding down here. Okay? 2 other things that we can do to help stop the bleeding are a fundal massage. After delivery, the uterus is going to be contracting, and while it's contracting, it can bleed, but we can help it contract quicker by doing the fundal massage. Who has children in here? Have you guys had your fundus massage?
Yes,
Was it
sir.
painful? It was painful, right? The nurses will go right in this suprapubic area, and they will just knead in there and rub it really hard. And the purpose is to try and stop the bleeding. Okay? That's one way. Another way to stop the bleeding is to encourage the mom to breastfeed. Okay? The mom can actually get the breastfeed, which can be difficult for first-time mothers, mind you. But if the mom can actually get the baby to start breastfeeding, that helps control the bleeding as well. All right. And then last, of course, we're going to document this on the PCR. We need to make sure and document a time of birth. That's important. The doctor's going to want to know that at the hospital. And then make sure and bring the placenta with you to the hospital. Real important in your documentation is your initial APGAR at 1 minute, your second APGAR at 5 minutes. Okay? Is there any instructors in here? Not even in here, are they? All right. Any questions about that? Did I cover it all? Yes.
Why does the doctor need to keep the placenta?
Why does the doctor need to keep it?
Yeah.
They don't keep it.
Or
They want to look at it.
why?
They want to make sure, because, for example, if you have placenta brevia, where the placenta is attached to the uterine wall, when the placenta detaches, there could be some damage to it. That damage then could lead to further problems with the baby. So the doctors
He
always
skipped a
want
lot
to look
since last
at the
semester.
placenta to make sure it just looks normal. Not only that, but they're also looking for arteries and veins in the umbilical cord. If you have too many arteries, not enough veins, or vice versa, that can also cause problems on the baby, or to warn them of future potential problems. Any other questions? No? Okay. So you guys are going to remain in here with Mr. Fontaine, I believe.
Real quick, while you guys are all